All right, so now we're going to shift gears a little bit, and Manish Parikh is going to talk to us about robotic PCI. How many of you use robotic PCI in your practice? Wow, we have a few avant-garde people here. Let's hear about it, Manish.
Okay, very good. So we're going to shift gears a little bit, and I'll try to stick to the time. So talk a little bit about percutaneous coronary intervention with robotic PCI, which is a little bit different and new, and I think important for all of us here. Robotics in the market is clearly here to stay. You know that robotics is used in industry outside of healthcare, but clearly the robotics market is going to go up several billion over the next few years. Now, for us in healthcare, how does that impact us and our practice? Clearly, the surgeons have taken the lead on the robotics procedures, but I think we really have something that we could utilize here. If you look at the market here, projected to be nearly $20 billion by 2021, up from $3.2 billion just a few years back. General surgery, vascular, orthopedics, many different players in the robotic field right now. And I'm going to talk to you a little bit about what's really near and dear to us, which is PCI. So to the left here is our friend Andreas Grunzig, for who we have to give credit to why we're here and what we're doing for our patients. But you see him standing to the right of the patient with an II. And what's changed in 2017? Absolutely nothing, right? We're still wearing lead. We're standing with maybe lighter lead, with less radiation, but still getting exposed. And wouldn't it be nice, like the person on the right, to be able to sit in a cockpit, do the entire procedure without lead in one of those, nice chairs and not have to worry about sweating it or seeing or visualization, and doing the entire procedure sitting down and being as successful as you would by standing next to the bedside. So really the need for robotics in the cath lab as a pipe dream is as following: consistency and reliability, integrating all of the imaging and FFR data as you've just seen, protecting us from both the radiation and also the orthopedic injuries that we're prone to, and also what about access for all patients? What about remote use in areas where we don't have capability of doing PCI? If you think about primary PCI in the United States, only 30% of patients with STEMIs are getting primary PCI. The rest of them are not in centers capable of doing primary PCI, and we know that even in the United States that would be the best, but we don't have access to that. So improving patient care is really what we're worried about and hoping to do. So this is the CorePath GRX. This is what our cockpit looks like. This is what Sunil has in his lab as well. You have a console, a robotic arm, could be either a femoral or radial procedure. You've got a very nice visualized high-def screen in front of you, 3 knobs. One moves the wire, one moves the balloon or stent, and one actively controls the guide as you would at the bedside. You have the capability of fluoro and cine as a foot pedal underneath that sort of chair-covered area, and you essentially, as long as somebody gets access, puts the catheter in, and loads equipment, everything else could be done robotically. So clearly for all of us, I think it's an important thing to know, our risk as interventionalists is going up. We know that brain tumors are predominantly left-sided. 85% of brain tumors in interventionalists originate on the left side. We know there's an increased risk of cataracts. And in our cath lab, out of 9 operators, 5 or 6 of them have had major back, spine, and hip operations in the last several years. So after the second decade of doing this at high volumes, all of us are going to feel the wear and tear of what we do. So what about using a system like this? We've shown a 95.2% radiation reduction to the physician when using the CoreLab robotic system. We also show a reduction to our staff because we're using actually less radiation. We're doing procedures quicker with less contrast as well. And this was published in JIC. It was a single center trial that both I and several other people at Columbia were involved with, showing manual PCI versus robotic PCI, and the fact that we were able to not only get the case done, but to reduce the amount of contrast, fluoro time, and the radiation dose, not just to us as operators, but to the patient and the staff. So the new CorePath GRX second generation system is here to stay. It's no longer a toy. It's no longer for type A lesions. It's no longer just a playground. You actually have very, very accurate haptics to do wire manipulation and to do guide and balloon delivery. And I must tell you that now, having done over 100 cases, there's almost no case that you can't achieve with the robot as long as you can manipulate one wire at a time. We do not have the ability to do 2 wires, 2 balloons or stents at a time at this present variation. That's going to be coming. But it must say that they've made some very, very nice improvements to the system. So let me show you what we're talking about. Why this? Why now? Why in our cath lab when administrators are beating the crap out of us about cost? First of all, I think procedural control is important. Radiation reduction we all need to fight for, just for ourselves and the future of this particular field. I think the robotic precision does have stent savings, something to go to the administration. I'll show you nearly an 8.3% savings because of the accuracy and also radiation reduction, as I suggested. The haptics and measurement tools on the robot give you the ability to measure accurately the lesion length, no matter where you are in the particular coronary tree. And it's by a millimeter accuracy. So today's challenges about geographic miss could be no longer using the accuracy of the robot. We've shown nearly an 8.3% stent reduction because of taking eyeball measurements, thinking that they're longer than they actually are, and reducing it from a 2-stent or 3-stent case to either a 1 or 2-stent case. I'll show you a couple of examples. This is in a long LAD lesion. Angiographically, it looks like greater than 1 stent. You can actually wire this with the guide in place, measure it. The CorePath measured this as a 37.7 millimeter lesion length. We pre-dilated and deployed a 38 millimeter stent, and you're done with the case. This was 1 stent saved. And there are many, many examples, as you can imagine, in your own lab. Also, accuracy. You know, as fellows in our lab, you say, go in a millimeter, come back a millimeter, move it in, move it out. Can you nail an ostium? Can you nail a bifurcation? With this particular advancement of the drug-eluting stent or balloon, you have exact 1 millimeter advancement back or forth. And I can show you several examples. This is a tight ostial ramus, pre-dilated and stented with the robot. If you could see it, you're going to get it because your delivery of product is exact. And when you inflate, there's absolutely no movement of any devices. Here's an ostial LAD. Again, you can nail it appropriately. Here's a couple of ostial rights. Very tough sometimes to engage. You can disengage your guide actively, deliver the balloon and stent, and nail the ostium. Here's an anastomotic lesion via lima that we've done, wired balloon, stented. Here's another ostial right, complex. Sometimes the fellows will struggle with nailing the ostium. There was a wire outside this. We've been able to nail it. So is this just for the type A lesion, or is this for all comers? And Shami Mahmood has been really integral in moving the space in robotic procedures. And this is his PCI trial, 334 procedures, 108 robotic, 226 with manual PCI. He not only showed that it was safe and effective, where you could get the procedure done, but we were all busy. We've got other rooms to go to. We've got to finish 10 cases in a day. The time to completion of these procedures was nearly the same as manual procedures. There is a learning curve. You do need to have buy-in from your staff. You need to have techs and fellows, and you need to work together in order to get proficient. But if you do that, it's actually very, very rewarding. Now with the radial craze, I think radial PCI is here to stay. I'm happy to see that that's happening, but most of us are going right radial. I think left radial is being less utilized because of this having to reach over is agony, okay? Even though it may be easier for fellows to learn left radial versus right radial. Nope. And we also know that right radial versus femoral or left radial has more radiation to the operator than our standard femoral and left radial procedures. And, you know, we'll talk to Sunil about what his thoughts are, but this is the data that we've seen. Clearly, right radial does have more radiation to the thorax than left radial and femoral. So this is the robotic trifecta, looking at patient benefit, physician benefit, and hospital benefit. Clearly, radial has a safer, faster ambulation. For the physician, if we can do left radial, clearly reduce radiation, reduce back strain. And in this particular presentation from Amin, and we're trying to duplicate this at Columbia, there's a reduced cost of radial versus a femoral case of nearly $916 per case. More to come. What's the future? When we started out with Grunsig, thank God, in 1977 with a standard manual procedure, that's what we still do today. I think the robot gives us an ability to reduce radiation, to do it safer, to do it more proficiently. But what about the future? What about artificial intelligence, data analytics, cloud computation? If we can do advanced device manipulation, if you can do this robotically, remotely, and have prescriptive analytics for bifurcations, for CTOs, it's no telling what you actually can do with this type of technology. And for me, this is the Holy Grail. Asia is very near and dear to me. Large burden of atherosclerosis, unmet need, very few centers. You could put this particular cockpit anywhere, as long as you have internet access and somebody on the other side that can get access and engage a guide, you can do this procedure remotely. I think this is the Holy Grail. I think this is exciting. I think this is here sooner than we think. And I think as interventionalists who really are at the forefront of this for our future, we need to support this technology. Thank you.